Approach to a child with dyspnea. It is different in different ages. Neonate has the immediate after birth. You have congenital pneumonia, you have aspiration pneumonia and difficult traumatic delivery. You have asphyxia. We have done your transient tachypnea newborn afterwards, and thereafter you have RDS, respiratory distress syndrome type 1, and then you have the other causes, the anomalous the respiratory tract, agenesis of the lung, tracheoesophageal fistula, and so forth. Even birth trauma with severe CNS insult can give rise to this sort of dyspnea, central dyspnea. So, how do you understand dyspnea? When child is breathing faster, there are subcostal, intercostal, and substernal recessions, flaring of the LNAG, and maybe danger signs with cyanosis, unable to drink and feed. Simply, they are all possible in severe cases. So, this severe sort of insult, severe sort of dyspnea, that should be admitted to hospital. They should be referred immediately. If it is not the case, you meticulously see the throat, count the respiratory rate, and you see whether the child by neonate is able to suck and swallow. And if they are all normal, you meticulously go to exclude the differentials like infective cause, CNS cause, structural anomalies, surfactant or lung deficiency now, and take measures accordingly. So you can do the ABG, arterial blood gas analysis, and if it is too low, less than 90, of course you refer the patient to the appropriate place. And the here is this an urgent sort of things. Priority is over there because neonatal death and pneumonial death, and then the severe sort of insult in the neonate asphyxia and others. They are the important causes of mortality, morbidity throughout the globe, all developing nations. So, there is question of urgency. Afterwards, in the infancy, you have recurrent sort of dyspnea, your asthma, you have pneumonia, you have bronchiolitis, you have tracheomalacia, bronchomalacia, and foreign body aspiration. So, take appropriate investigations, maybe one X-ray to exclude foreign body, and others have their own investigations. Suppose the bronchoscopy, tracheoscopy in the case of bronchomalacia and tracheomalacia. Then the pneumonia has fever usually. Thereafter, the youngest subset, you may not have any, much fever. But afterwards, you may have fever, you have a toxemia. Toxemia, you have higher respiratory rate, you have recession, you have increased walk breathing. So apart from that, you may have danger signs, thus lethargy, unable to drink and feed, cyanosis, even convulsion, hypoxic, sort of insult, and the respiratory rate cutoff value over here is the 50. In the neonate, it is 60 to define severe pneumonia. So in 50, in the 2 months to 1 year, thereafter it is 40 up to 5 months, and adolescents and adult after 5 years even you have 30. So define severe pneumonia to avoid the unnecessary death. You give over here the appropriate IV antibiotic. In other cases, you give oral. So, and other supportive cares in asthma, you give preventers, you give relievers, you give other supportive cares. So, it's important to identify dyspnea and grade it and identify the cause of dyspnea. Congenital heart disease over here is important differentials. They are to be excluded. How? The murmur. In extremely dyspneic subject, you may not hear murmur. But when the child is settled a little bit, you have murmur of the congenital heart disease. Suppose BSD, it has a third and fourth space with your pansystolic murmur. The PDA in the left second intercostal space in the and and others have their murmurs in the appropriate location. They come in the second week something, but in the day 1 and 2, you have more some important diseases like TGA, transposition. If you do not diagnose it early, perhaps you are missing the train. Thereby, do one echo over here, and these children may not have murmur if they do not have the left to right communications. They are silenced obviously most of the time, and they need intervention within 2 weeks. Then others also anomalous origin of the left coronary artery, your the total anomalous pulmonary venous drainage, abstain anomaly, single ventricle, they need immediate address to avoid unnecessary death. They need to center in a good place. So apart from the murmur, you have the heart cases, you have features of left ventricular failure, tachypnea, tachycardia, gallop, orthopnea, and basal capitations. You may not hear everything in single patient. You may hear in various combinations. You may not have anything. You have only one thing. So it depends. And when long-standing LVF can have in the raised JBP, which is difficult to see in under 2 years age group, and also tender hepatomegaly and pedal edema. So neonatal pedal edema can be due to the hypoalbuminemia also. So do that if you feel like. And the above that you have in above 5 years or so you have pneumonia again, you have asthma, and you have asthma has their own finding. The prolonged expiration, your wheezes, your the related bronchodilator. Then the adolescence group at the 30 respiratory rate cut-off value, and along with it, there are other features of pneumonia, mostly fever, and the lung findings, the coarse crackles. In heart failure, you have fine crackles. So this is the way that you differentiate the dyspnea in children, and you identify the cause and treat accordingly.